Well, good afternoon, everybody, or good morning, depending on where you are. My name is Garrett Schmidt, and I am the CEO and managing editor for VBC Exhibit Hall. And I would like to welcome you all to today's live webinar that is hosted by Credo. And very excited to hear about this one. It is titled An HCC V28 State of the Union, the key to excelling at VBC in 2024. So there's a lot of great material here and excited to hear from our speaker who I'll introduce in just a moment. A few items of just some housekeeping things. We're going to have a time for Q&A towards the end of the presentation. So if you have a question that you would like to ask, go ahead and drop it into, there's a place for questions in your little module there. And we're going to get to as many of those as we can. If for some reason we run out of time or we're not able to get to yours, don't worry. Someone will reach out via email afterwards and make sure we answer your question. So even if we're wrapping up at the last second, go ahead and ask your question. Next, the session is being recorded today. So what's going to happen is after we're done, we conclude, you'll receive an email, maybe an hour or two at the most afterwards, and there'll be a link to the recording and also where you can download the slides, and you can find out some more information about it there, and you'll be able to get in touch with them and whatnot if you would prefer. And without further ado, I'd like to introduce our speaker today, Mr. Carm Huntress, who's a friend of mine and a good guy, and he is the CEO of Credo. So welcome, Carm.
Yeah, Garrett, thanks so much for having me today, and really excited about the webinar, and we're going to jump right into it. And so, I think the first thing I'll say to everybody is this has been, probably one of the hottest topics in terms of, this transition into V28 that's now started this calendar year. A lot of concern, both from payers and risk-bearing entities in VBC of how to address this, how to think about a new world era, and doing the best job possible within our organizations to risk adjust our populations in the right ways. And so, just for those who are new and maybe haven't stayed on top of the news, there's quite a few changes here in the new model, going from V24 to V28. There's been an addition of 29 HCCs that previously were not part of the model in terms of diagnoses that are codable. But then the bigger part is 2,000 codes have been removed. And I think this is one of the things we'll talk more about today to do this really, really well. You really have to ensure your risk adjustment processes are at their highest possible level, and that you're doing everything you can to make sure all the patients' diagnoses that are being treated are documented appropriately. And we're also seeing, we did a webinar about, I don't know, 3 or 4 months ago, I'd say. And what we found was that a lot of organizations were still trying to figure out the impact. This isn't necessarily the easiest thing to do, especially when you got a lot of other things going on. And we've seen revenue based on our servicing, some pretty large revenue adjustments out there, anywhere from 5 to 23%. And so, a lot of organizations are trying to figure it out still, understanding the revenue adjustments that are affecting them, and then prioritization of their efforts and trying to improve their risk adjustment processes. So that's where we are today. So we're going to start off with a first poll question here. And I think Garrett's going to come back on to help us do this. But this really is a question of sustainability and survival in some aspects. We have seen groups, probably the most public one is with Cano, of, if they're going to, financially succeed. And so it's just such an interesting state of affairs of, hey, I think we've got an existential crisis here. I don't think we've got, appropriate risk adjustment processes in place to make this financially work. In our organization, I expect, I'm prepared, or maybe I think I'll do even better. And or I'm not sure, which is also a fine answer. So I'm watching here in real time on my other screen, a lot of really good answers coming in. It's kind of interesting. So we'll let this go just for another, I don't know, 10 or 15 seconds. So wrap up if you haven't put in your answer, and we'll wrap. So I do think it's super interesting, where these results are landing, as I'm watching them come here in real time. But let's cut over. Garrett, I'm assuming you're going to bring these up here for people to
Yeah,
see.
looks like
Um,
we've still got some results in, so maybe give it about 5 more long seconds here, and then I will
okay, great.
pull up the results. And by the way, just so the audience knows, this is anonymous, so don't worry about that. We're not going to share your information, but what we will do is show you kind of where you stack among your colleagues here. So don't worry about about that. You won't. All right, and I think all right. Let's go ahead and share the results here. Okay, so you should see that on your screen. Are you seeing that,
Uh,
Connor?
I don't know if I'm seeing on my screen. I'm seeing it says you're sharing your screen, but I can start reading those out. So
Yeah.
I think so the biggest category is I'm not sure. So 60% of people said I'm not sure. Now that I'm sure there's some people on the webinar that maybe are just, listening for other reasons or for educational reasons, and maybe this isn't an ongoing concern. But I also say, based on our past webinars, this is really common. I've, we hear this more and more. I don't know what the impact is yet, and we're obviously paying close attention to this because initial sort of checks for those, doing value-based care are going to start showing up here in the next couple months. And so I think people are going to get more aware of what the impact's going to be. The second category that got 30%, I do expect some revenue uh, correction, but I feel prepared. So I think that's a good sign that, one of every three feel prepared. And then, the last two is interesting. 7%, which, I was not expecting a number this high even, but I do not think will financially succeed. So boy, if 10% of providers and payers in this space do not think they'll financially succeed under V28. That's a pretty scary statistic. But I think really educational, and that this is a very important initiative in terms of your organization, staying on top of risk adjustment, staying on top of these models, making sure your populations are well risk adjusted, and you've got the right processes in place to do it well, more important than ever. And then the last group got 5%. Some, that, hey, one of every 20 says, hey, we're going to do better under the V28 model. Don't hear that often, but also some great results there. So um, really, really interesting on that first poll. So let's keep going here. So look, I think we try to sort of talk to clients about three really big things as you're sort of, hey, I got to get my strategy right here for V28 and our risk adjustment process. The first thing I would say, is, and I'll probably start with the middle, is a comprehensive risk adjustment strategy. And, you can break these things down into categories. I tend to think about core functionality, right? Is what are we doing about, suspective, prospective, retrospective, and concurrent? And I'm sort of talking from a VBC provider perspective, maybe not the payer, because some of these things like concurrent is more of a provider function than a payer function. But those are the four big areas that we kind of talk about. And so sort of giving yourself a rating on how am I doing across these categories. And that can be a big issue. Now, if I go to the one on the left, you know, a lot of what we see in the market is sort of outdated paper-based risk adjustment processes where, on the payer side, still really antiquated chart chasing processes, and trying to do suspect or retrospective analysis, and that can be a very cumbersome and costly and sort of time dependent efforts, that can be outdated. And we'll talk more about what's shifting in the market in terms of national interoperability that's opening up doors to move beyond some of these processes or extend them into digital. And then really the last thing is, talking about integrations and supporting the provider at the point of care. You might have a lot of, and this also ties into the paper problem. If you're a VBC provider today doing risk adjustment, how are you interacting with your providers with that data from various payers at the point of care? And what is the capability you have to move beyond paper, maybe beyond logging into a payer portal and getting sort of a patient overview that may include risk adjustment information or gap data, diagnosis gap data, and moving that to more of a digital at the point of care in workflow capability, which is really where I think the market is headed over the next few years. So we really look at these as limiting success things where you can kind of go in and say, hey, how are we doing in these categories? Where's their area for improvement, and how do I think about that? Um, when and again at Credo, we spend a lot of time with value-based care providers who are taking full or partial capitated risk. And we're seeing a lot of outdated processes, right? And I think this is also informative to payers as they think about their network or provider enablement teams and how they're interacting with those clinical partners, and where we're seeing issues that are related to having a healthy risk adjustment process. So if you're sitting there saying the first thing is like, hey, if I want to do risk adjustment, well, I better have all the clinical data on these patients. We see most outpatient clinics spending an hour and a half per day at their front desk of administrative time, chasing charts, trying to get those patients prepped for that visit. That's a lot of time. And or to estimate every time a provider organization has to sort of initiate a fax to get a record, it's kind of $20 of labor cost that's going out the door, because you got to fax it, you have to do the follow up, you've got to get the fax back, maybe upload it to the EHR, make sure the provider sees it coming into the appointment. Those and even signing the HIPAA release, right? Those are all costly efforts around chart chasing, to support risk adjustment efforts potentially for an individual patient. Then on the provider side, you've got them spending, we think about 5 hours is what our uh, uh, time per week reviewing patient charts, coming, the night before, the day of, coming into a visit, trying to get up to speed on what's in the EHR and figuring all that out. They might have some history there. And then, a lot of the time they're only getting like one record. They're not getting a lot of comprehensive data prior to that first visit. So still spending a lot of time, but not with a lot of really good high quality data. Um, you know, there's also a lot of times where you might have a risk adjustment process post encounter that's reviewing charts and doing kind of concurrent coding. We're really saying to the market, what's your pre-encounter risk adjustment processes, and are you thinking about in that way? How do we help the patient and the provider really understand from a suspect perspective or a prospect perspective, what diagnoses does this patient have, and how do we look at them? We think there's about 25% of missing, reported conditions not getting in front of the provider coming into that first visit. So massive problems today, from the front desk to the provider to risk adjustment processes, to get this right, whether you're a VBC provider or a payer trying to enable providers to take risks and have a health and work with them to have a healthy risk adjustment process. And so we just talked about some of this stuff, but I want to emphasize it is like, V28, if you kind of fundamentally look at it, you can't, there's kind of no more cutting corners or no more lackadaisical processes around risk adjustment. We think that's really where the existential crisis is occurring is, hey, just lack of really good processes. I can't get my population well risk adjusted. My providers aren't doing the work and the coding right. And so we see that. We talked about the front desk problems in terms of these manual and outdated processes. If we're not, doing the right job on the risk adjusters, whether you have your own in-house team or that outsourced team, are they doing all the right functions of risk adjustment in terms of prospective, retrospective, suspective, concurrent, and how well are those processes working? From a clinician standpoint, right? How are we really getting this data from various payers in front of providers in the right ways that really help them make better decisions? And then lastly, technology. Paper and portals are becoming more out of date and really hard to manage from a clinical perspective. And but they're still the dominant solutions. We run into many value-based care providers in the market that are still mainly working on paper today, or PDFs, or the digital PDFs, I guess I would say. So we've got a long way to go to get this more of a technology enabled capability. So let's jump to our next poll question is, if you are growing, your value-based care, population, maybe that's, in Medicare Advantage, maybe that's in ACO or ACO Reach, maybe that's in MSSP. Are we, hey, I'm out, this is too risky in terms of thinking about risk adjustment and doing this well. We're going to stay steady state and just try to shore up our current populations, and we're not thinking about growth, right? This isn't growth at all costs. This is about profitability, maybe. The next one, right? But we're kind of moving into the affiliate world, right? Where, hey, I'm not going to go buy more clinics if I'm maybe you're a MSO that's buying up clinics. We're going to do affiliates only this year. And then maybe we'll plan to continue to grow through acquisition of net new or distressed practices. So really a lot of interesting options there. I'm excited to see what people say around this on the webinar today. This is a big question mark. I think for those who pay attention to public companies in the space, we were kind of blown away by Agilon's results in the first quarter here. And, if people don't know, Agilon's a big public MSO, managing hundreds of thousands of lives today. And, their big concern was their, affiliate and newer practices than their, mature own practices that had very good risk adjustment processes and were managing their populations well and had very healthy, margins on those populations versus the net new clinics and populations that were earlier on in their development were showing very low or almost losing money. And so their message was like, hey, we're not going to keep growing, we're going to grow some, but our focus is really shoring up those current populations and those affiliates to make sure they have healthy risk adjustment processes and they look more like our mature practices in terms of getting the margins right. So I think we should be wrapping up here. It's sort of settled
Yeah,
down.
let me go ahead and share the results.
Yep.
And again, this is anonymous, so all right. Are you able to see that, Carm?
Yeah, I can see him over here. So it was a tie. Really interesting. So 42% said, "Hey, we're going to go steady state," which I think is a really good, very fair answer. And then another 42%, so 84% total, but another 42 said we plan on growing through affiliate relationships only. We have seen a lot of this. I think that's actually what maybe we were expecting, is that a lot of organizations are moving to that strategy of, hey, we might not buy as many clinics, as we were planning. We're going to work on affiliates and establishing those relationships. So I think that's great. Only 2% said they're going to shrink. They're going to pull back, right? So nobody's leaving, right? That's a good news. Everybody's committed to value-based care and for the most part, either staying steady state or growing. Now, we did have 15% saying, hey, I still want to grow, which is a healthy, set of people saying, hey, we're going to grow. We're going to keep acquiring. There's going to be more, and I think this is true based on what we saw with Cano, that there'll be distressed practices out there and organizations that might fit better in a more mature VBC group. So I think D is an interesting answer there with 15%. All right, well, let's keep going here on the through the presentation today. So, this is a big one to pay attention to because this is a national crisis we're all facing in terms of provider burnout. And we think there are key things related to risk adjustment and coding that are burning out providers today. So the first thing I want to touch on is just the national statistic, right? 1 of every 2 providers are feeling burnt out in 2024. I think about these things from an administrative perspective and how much overhead providers have to deal with that is so not related to patient care, in terms of, documenting things in the EHR, in terms of doing other administrative things pre and post visit that really doesn't have to do with care, that are just part of surviving in the U.S. healthcare system, but more importantly in value-based care. Now, the second statistic's really interesting in that 62% say administrative tasks are the biggest contribution, right? So now we're saying a little bit more finely, like, okay, there's all this stuff doctors have to deal, but it's these administrative tasks. You know, doctors aren't really doctors anymore. There's this funny cartoon I always reference where, it's this cartoon showing the doctor treating the computer more than they're treating the patient, right? Their focus is on the computer and computer screen. And I would say if any of you have been to a doctor's appointment lately, it feels that way a lot of the time, where they're more focused on the computer than really connecting and interacting with you as a patient. And that is another administrative task. And the other part is, hey, are we recognizing this? Are we really having discussions about the employers recognizing that there is burnout? And so when we tie this back to the story of value-based care and risk adjustment, we think this is a lot of the problem, in that they're chart chasing, they're going through a lot of paper-based processes in terms of medical record reviews or coding tasks of here's the diagnosis gaps and quality gaps from this particular payer, but we've got all these different payer relationships and all the data is coming in different ways, and that's really leading to this burnout. And we think it's a big part of it. I mean, charting and documentation is a huge challenge for doctors, and we make it even harder because we want them to code as well. And so that all revolves around chart chasing, records, and those types of administrative tasks. So big challenge here for providers that we need to recognize. So I love this question, just to say, hey, if how much time are you actually spending? Do you think your staff spends, chasing records, getting patients prepped, that type of thing? Very curious what people think here from a poll perspective. Um, and I will give people a hint. Nobody said under an hour already, so everybody's in the zero category. The zero category, or 0 to 1, is we have yet to see a vote. I'll let anybody know if someone's going to come in, but hint on early results here. So this is fascinating. Some really interesting results. So this is missed stuff, right? That I would just say sometimes is not a focal point in terms of thinking about burnout, in terms of thinking about how do we improve our risk adjustment processes. Having and getting complete medical record data on your patients and making sure that's getting in front of the provider is vital, but is really time consuming. And how do we create a more efficient process? But one, to reduce the burnout, but two, build a more efficient, effective process to make sure we're getting the right information in front of providers to help them make the best decisions possible on your patient population. So I think we're kind of wrapping up here, Garrett. I think we're getting
Yeah, all
there.
right. Let me go ahead and share the results here.
So lo and behold, I'll go through. I'll just go through them because they're kind of right down the middle in terms of three of them. Zero. Nobody is spending under an hour a day. If you've got this activity, it's more than an hour a day. So that was a 0% there. The next one, 1 to 3 got 33%, 3 to 5 got 38, and 5+ got 29%. So super interesting results there. But we can say, hey, 1 to 5+ hours a day is a pretty good range. But man, I can't believe a 30%, 5 hours a day. Yeah, I think that's I'm actually probably most surprised by that statistic. I didn't think it would be that high, but that means way too much time, chasing charts. This is a really big administrative burnout. And when you think about those vital people in your front staff, managing those patients, bringing them in, and their satisfaction with their work, I would argue the more time they have to spend chasing charts, doing faxes, calling other providers, uploading these charts. This is not good use of their time, right? We want everybody at the highest, the top of their license, as we say. This is something that I think we all got to pay attention to, and really interesting results there. So let's keep going here on the process. So we want to talk a little bit about, how these processes, when you think about, you know the current state of the state, when we think about risk adjustment processes. So a patient, let's start on the left. A patient comes in, they have a visit, it's coded, right? A risk adjuster will code that, and then claims are submitted, for risk adjustment for that patient. Then that goes up to a payer, and a payer today, either with their homegrown technology or with vendors out in the market today, is doing that suspect and prospective, and even retrospective processes in terms of identifying diagnoses in those charts based on that claim data, and doing the chart chasing for those charts. And they're also doing things for quality like HEDIS, and doing chart chasing there. And then what happens, from there, is that you get diagnosis and quality gap data flow out of those processes. And then guess what we do? We push that back into portals, into emails, into spreadsheets, all sorts of different methodologies to push that back to the provider to accept or reject all that data, during the next visit. And that can take 60, 90 days between, that first visit, and then maybe seeing the patient again with that data. I think we can all agree this is a pretty inefficient process. And I would say in our experience, we've found a lot of claim suspect data. We work with value-based care providers. That data is really hard to digest. A lot of the times, these providers are just getting lists of HCCs that are just saying, hey, based on this claim, or maybe a chart that we suspected, here's this diagnosis gap. Just having that is a nice to have, but I don't really think affects, providers, the way they care for patients, and it's really a burden on them. And a lot of the times, I'd say the last thing, because of the delay between the patient visit and the claim, and then this process, that a lot of this stuff gets cleared up. And so by the time it gets back to the provider, they say, wait, I've already dealt with this. Why are you telling me about something I've already dealt with this patient? So this is the current process today, which we think can be really, really improved. So, at Credo, and what we're trying to do and educate the market about, and this really starts with, um, understanding, and I think I'll talk about it for a minute here, what's come to be, out of these new national networks. Have people heard of Commonwealth or Care Quality, which are the two dominant networks in the US, to bring together complete digital medical records on individuals? And so, we do this work today for groups where we say, hey, you've got this phone and fax process. As we just learned, you're spending hours, to 5 hours plus a day, chasing charts. We can now move you from paper-based and faxing and calling other clinics to pulling data digitally on a patient before they show up. And today, for example, on this process, is and there's a lot of really good data out there, and this is connecting into HIEs, connecting into other EHRs. We today, for an average Medicare Advantage member, get 50 charts. And those charts, a half of them are typically, from the last 2 years, and then the other half are from past, beyond that. And so there's just a lot of fantastic clinical data out there that could eliminate a lot of these processes. And then what we try to do and help, providers get in uh, in the process of doing as patients are coming in, is we analyze all that data to identify prospective, retrospective, suspect codes, and push that quality data with the clinical data directly into the EHR workflow. And we think this is the new world era. We think that because of national interoperability, this is now the way we should start to think about a healthy risk adjustment process. And yeah, it's great to get data from payers and help you understand your process in terms of different types of gaps. But we think, why don't we just start with the complete medical record of a patient, analyze that, and get that in front of the provider for that upcoming visit? That's really the big change that we're seeing in the market today. So this is how our pipeline works today, where we have thousands of clinics today sending us upcoming appointments. We pull records from these national networks, we analyze them, we use both AI and machine learning, but we actually have humans in the loop reviewing these charts, coming into the appointment. And then we do what we call sort of clinical clustering and summarization. And then we have partners like Vim, who you might know, that's an EHR overlay tool, or we can push the reports into the provider inbox so they have that coming into the appointment, and they can have this clinical summary, this wonderful, rich clinical summary of the patient's conditions from all the records that we were able to uncover. And then you just have a healthy process of, oh, okay, here's the diagnoses I know about, here's the history, here's the things I need to code for and build assessment of plans around these diagnoses, and do that all simultaneously during the patient encounter. So this is sort of how we've started to rethink with the PreDX platform, of a really, really healthy risk adjustment process that starts, as that patient's coming into that first visit. And so this is really where we think it's transformative in terms of clinical integration and where we can go with the EHRs. So we have the capability in an overlay to show this here, like this example of unspecified protein count malnutrition, where we're surfacing this little panel in workflow that shows, hey, this patient has this, they have vascular disease and dementia, but then we have the references clinically tied to that. So now I can just go and look at that stuff in real time, and I can agree and dismiss. And if we agree, we can put that right into workflow. And, this is all about actionable insights at the point of care. And what's great about this type of workflow is it's actually saving the provider clicks, right? We're making it easier on them, not harder, because all I have to do is click, oh, I see the protein count malnutrition. I can read the clinical evidence and the source data, and I can accept, or I can dismiss, or do another lab or whatever I have to do. But I don't have to type a bunch of things to get this into my assessment and plan. I can just agree and write it directly into the EHR, or uh, dismiss it and follow up. And we're also tracking all this data, which is really impactful. And so this is just sort of a study result we wanted to share today of how you can start to change the risk adjustment process, and get some real operational savings, as we talked about in terms of chart chasing. So the first thing is, with our manual, and digital efforts, we've been able to get, 98% of at least one record back on every patient. Most clinics we see today are anywhere from 10% to 50%. They'll get a chart before the first visit. So kind of 2 times better than the best providers we've seen out there in terms of getting charts. And if you have the digital connectivity into national networks, you can get a massive amount of data back. So 71 in this case study, which was in the New England area, we got 71 charts before the first visit, right? A lot of people ask how many pages that is. It's a roughly 1,000 pages of history on a patient coming into that visit. And so in terms of suspecting, and what we found was on the V28, and this is on V28, I won't talk V24, we found 0.286 of net new risk adjustment HCC codes that were in the clinical data that we wanted the provider to review. And then we're seeing a 72% acceptance rate of those HCC gaps. So this is really demonstrable and a sea change in terms of other processes that might be based on claims or post-visit endeavors, in doing all this work in a thoughtful way upfront before that patient comes into the visit, and getting all this data in. We don't have the studies yet, but I think one thing I would add that we're really curious about is, if I'm on average finding 0.2 of a point of new, HCC value, that means I'm finding maybe 1 to 2 additional conditions that weren't treated. And that means we're actually getting ahead of potentially really costly things for a patient. It means we're getting up front and treating diseases that otherwise would be missed. I had somebody, primary care doc I was with a few months ago, and they said to me, I had a patient that came in, and it was the third time I had seen him in a year, and they mentioned on the third visit that they had cancer. And I said, why didn't you tell me in the other 2 visits I had with you earlier this year? And they said, well, you're not my oncologist. I didn't think it mattered. And wow, that's, I think a challenging conversation, but I think points to, if that provider had the complete clinical history on that patient going into the visit, they would have addressed and talked through the cancer and make sure it's being well taken care of, and what's going on with your oncologist, and are you seeing them on a regular basis, and trying to avoid things like costly hospitalizations. So I think there's a MedX cost argument here, which I'm very excited about. But we know we're definitely helping providers get more prepared and have all this complete clinical information going into an appointment. So let's move on to the next, well, just asking about capabilities. We'd love to better understand what you may or may not have today, and where you are on a continuum of constantly improving your risk adjustment processes. So let's see what people think about this. And I'll just go through things. Are you doing things digitally today? Do you have connectivity in an HIE maybe to get data? Are you doing a pre-encounter medical review? How often is that happening? Uh, you know, we have EHR integrated tools today that are tied into directly in workflow and helping the providers make these decisions. And do we have end-to-end tracking? And is that happening today? So these are big areas where they could be meaningful areas for you to improve and start to think about how you might do that. So we're getting a decent number of votes here coming in. And really interesting responses here. Still getting more votes are coming in. Appreciate everybody. If you do have, if this is part of your, organization, would love to know, what you're doing today. And again, as Garrett said, these are completely anonymous. And let's just give it one more minute here. Okay, let's start. Well, still getting a few more votes here, almost. Let's just give it one more minute. A lot of people are thinking this one through. Okay, well, let's start to wrap here. I don't know, Garrett, if you want to put it up. We got about a
Yeah,
good
we'll give it.
number of people voted here, which I think is great. So
All right, let me go ahead and share the results here, and you should see it.
yeah, so I think this is great. So the biggest one that got the most votes is actually, we've got some, EHR integrated risk adjustment tools. That's great, 2/3, right? But still a third of people without that tooling today. That's a big area of, like, how can we make that doctor coding process more efficient and easy and simple? The next one, right, is a pre-encounter medical record review. So this is a big one, right? Only 1 of every 2 people said they've got that. So, that's one area where you can think about, hey, if we could do more of this pre-encounter review, we could help the doctor better code and make sure they're well informed about that patient and anything that's happened since the last visit, or if it's the first time you've seen a patient, are we helping them, do that medical record review? And then the last 2 kind of side by side here, 1 in every 3 doing digital. So, a lot of opportunity for improvement. There are 2/3 of people without digital record review. That's a big deal. And then only a third doing end-to-end tracking. And so, again, another big opportunity to say, how well are we actually performing on acceptance or rejection of this type of data in terms of HCC diagnosis or quality gap data? And, where could we improve there? So some really great answers there and really good insights into where organizations are today. Thanks for that poll, and I'll take it back over. And I actually think we went through that pretty quickly today. So I'm hoping, Garrett, we've got some good questions, but we covered a lot of ground, and I love that last poll question. So, Garrett, why don't you come back on and let's see what questions we have?
Yeah, sounds good. And we did have a number of audience questions that came in. So if you do have a question for Carm, go ahead and drop it in now using your little module. There's a place for questions specifically. If we don't get to yours, by the way, don't worry. Someone will reach out via email afterwards. So go ahead and put it in. Okay, in no particular order, let's go ahead and dive in. This question is, what do you mean by suspective coding? I've never heard of this term before. And what would this entail and how would it be used in RA?
Okay, great. Wow. Okay, so some people, I would say, number one, if you know prospective, this can somewhat be interchanged, but I have a nuanced answer there. So let's just go through each one, and we'll start with suspect because that was where your question is, but we'll touch on the others, which will hopefully answer your question. So suspect is, um, I am looking at a history of a chart, and a previous provider has indicated the presence of a code, but it's of a potential diagnosis, and it's not well investigated. So, this is something that's totally suspect in nature, right? I don't know, but I have some inkling. An example would be maybe something very suspect. You could suspect an A1C for a diabetic, right? You sort of look at their A1Cs and they go, wait a minute, they don't have any diagnosis of diabetes, but they got a 7.5 here on their A1C. That could be, oh, wait, let's suspect that. We need to investigate with the patient, are they experiencing, diabetes. And so that's where we're using clinical data to kind of give an idea of what's happening. Prospective, the way we look at prospective is, hey, it looks like the condition is present, and it's documented, but there isn't an assessment and plan. So we've got a present condition. I need to get that figured out. And then you've got retrospective, which is, wow, this was present, and there was previous assessment and plans set, but we never coded for it, right? And so a lot of payers today have retrospective, and there's a lot of vendors out there that do retrospective coding for payers. Um, so those are the different functions. And then the last one maybe to mention is concurrent, which is I've just seen the patient on that provider, and then my risk adjustment team post encounter is helping me and looking at coding and making sure, hey, have I coded it correctly in a compliant way? Do I have assessment and plans? Have I meet criteria? All those things in terms of concurrent. So hopefully that gives you a sense of how we think about those different categories. But I have met with people that say, oh, well, prospective is suspecting. It kind of depends, but I really think of suspective is really clinical in nature, and it's focus on finding those diagnoses that are kind of there but need more work and investigation, and then building an assessment and plan from there.
Wonderful. All right, next question is, let's see. This is more of a statement, so let me go on to a different question here. Got a lot of questions coming in, so go ahead and ask yours. For value-based care contracts with rates based on risk scores, an increase in risk scores, to give some specific numbers here, would mean an absolute windfall in extra shared savings. Does this not lead to conflicts with payers offering these arrangements?
No, not because of MLR. So if you think about it, a payer sitting there from an MA perspective, and they're delegating a risk down to a VBC provider, and then that provider's taken on that risk. And so if the provider is really good at risk adjusting the population and treating those conditions, and rightly so, yes, the dollars will increase, but the pie gets bigger in terms of the premium you're making off the member. And then again, if you're treating those conditions earlier and more upfront, and not letting them kind of progress, you should see a lower medical cost, right? Because we're getting ahead of issues and dealing with them up front. And so less hospitalizations, right? Less readmissions, those type of things. So again, if you can risk adjust your population better and more accurately and find those diagnoses, the pie will get bigger. And so the MLR ratio will improve, or the dollars on the MLR ratio from a payer, they'll end up making more money. But on the delegated risk side, if you can lower that cost, then there's more margin for you on the delegated risk side. So ultimately, the payer and the provider under a risk arrangement are aligned to do this really, really well. So hopefully that answers your question, and it helps you understand why this is an important function within risk-bearing entities, especially if you're taking delegated risk.
Wonderful. And this next question, it says, what does that look like? And I'm not sure exactly what they're referring to, but you may pick up on it. What does that look like with ECW, or is it a separate portal, or does it arrive in an ECW bucket? I'm not sure if this is
Yeah, so
you're
we
tracking
have
on this.
I think they're asking about the EHR integration. So
Okay.
in ECW today, our the tooling, and as everybody knows, we have a partnership with Vim, which overlays on ECW. So as the providers in the assessment and planning phase within ECW, our tooling or our data alongside the Vim capability surfaces as like a side panel inside the EHR, and you can then just open up. It'll highlight for this patient as you're doing the assessment plan. Maybe there's 3 or 4 diagnosis gaps and one quality gap. You can open that up and then accept or dismiss in real time inside your documentation in ECW. So again, we're trying to encourage providers, start to, and some of these EHRs have their own tooling, and we can integrate into that, but a lot of them are forcing you to go, click around or go off into a portal, to do that work. We're saying, hey, let's get this integrated into the clinical workflow, streamlines it to the providers, easier to train. They don't have to be coding experts, right? They can just accept, oh yeah, that condition is present. I don't know that that's E46, but the
Right.
software's telling me it is. So now I don't have to deal with that part. So that's what's going on in terms of ECW, but we fully integrate into ECW and Athena and many other EHRs today with that capability.
Very good. I'm glad you understood that question because that was over my head.
It's not it's a common one. It's a very common one, Garrett. So I like that.
Good, good, good. All right, next question is, can you speak more on the influence of nationwide interoperability, such as TEFCA's implementation?
Sure, sure. So, um, the national networks it was first regulated under the 21st Century Cures Act, and something was set up called TEFCA, which is the Trusted Exchange Framework and Common Agreement. And the thing, just to make it easy, is think about the last two, the C and the A, which is common agreement. What we've never had nationally, if you think about it, you have all these health information exchanges, you have all these EHRs, you have all these clinical systems, and pretty much on a state basis, we regulate how data, and really on an individual provider to provider or provider to payer way, data is exchanged, and we don't have a common way of doing that. So the US government said, hey, we invested $30 billion into all these EHRs and digitizing medical records. We need to open it up and now create a connected, interoperable national network under a set of common agreements to pull that data digitally. And so TEFCA, which is in its final phases, and maybe you've heard and you can do research on QHINs, which are qualified health information networks, have now been established nationally. And so the common agreement use case that's been sort of established initially is what's called treatment. So if you're treating a patient, if you're a provider treating a patient, you can just ping these networks. The two big ones are Commonwealth and Care Quality, which are weaving together all the HIEs and EHRs to ping the networks and then get all the data back on a patient. And like I said, today for a Medicare Advantage member, we get about 50 charts. So while these networks are still in their infancy, there's a lot of really good data for the treatment, use case under the common agreement. There are other use cases like an individual like you and I being able to get data off the TEFCA networks from individual use. There's other things coming in future years under payment and operations. So a payer can make a request to a provider to get data. under the common agreement. So that's a little 101 on TEFCA and the national networks and what's happening in terms of opening up national interoperability so we can, finally move away from practices like fax and signing HIPAA releases into doing this all digitally and imagining a future where I might have seen 10 or 20 providers in my along my health history, and now I have a way of just getting all that data from all those providers all at once without having to go one by one, call up all those providers and get that data. You're muted, Garrett. Sorry.
My apologies. Moving right along here, there is a greater emphasis today on the patient experience, which is good and appropriate. Karan, can you touch on this as a result of Credo's product and value prop?
Yeah, for sure. I think what's really interesting here is I think we can all imagine this story and what it would mean to us and what's changing now that we can get all this medical history, and that I come into an appointment today. And previously, a doctor would walk in and typically just start an exam, right? Start asking me questions. And a lot of times it's hard for patients to remember their conditions, to remember what procedures they have had, to remember even the names of the diseases that they have. And that's a big problem. And so when we think about the effect on the patient, and we all can imagine this, imagine walking into a provider's office and they have all your history summarized in front of them. They know the medications you're on. They know your recent lab results. They know your diagnosis. They know where you are on your treatment path and the progression of any disease you might have. And they can talk to you through it. And that's really the hope at Credo. Yes, we have a big focus on risk adjustment and quality and making sure that our organizations we work with have the best possible processes in terms of doing that very well in a world that's ever changing with V28. But ultimately, we care deeply about the patient experience. And the fact that we can create a technology solution that informs the doctor in that way with the complete history is just a sea change, and to a point where we have clients today that do NPS scores on their patient visits, and they've shown clinics where we're live in and working with the providers, they're having higher NPS scores. And it also ties back to things like CAP scores in terms of this question of did the provider understand my medical history coming into the exam? And they do. And this is really the thing that we're under all this really excited about, because I think we all deserve that as patients, right? That's the future I think we all want, where our doctor is a well-informed partner around our clinical history and really informed coming into every appointment. So that's some of the stuff we've seen on the patient side.
That's fantastic. This one should be a quick answer. Does this work with Epic?
It does work with Epic. So yeah, we have integrations into Epic today. And what's great about Epic, right? They have a lot of, they have care everywhere and they have a lot of data on patients. What's great about kind of what we're trying to do is saying, hey, there's a lot of actual outpatient data outside of an Epic, integration, and you might have some of the patient's medical record, but there's a lot of ambulatory specialty care, things like that might have happened to the patient that we'll push into Epic and provide as part of our clinical summarization. So yeah, we do have integrations at Epic today, and are excited to bring all that additional helpful, informative data into those encounters to support patient care at Epic sites.
Great. All right. Next question here. Still have time for a couple more. Is what primary source CMS verified algorithm do you use to perform your record analysis to identify quality and care gaps?
Well, that has been completely homegrown. And so we I would say today are probably more in the NLP camp than in the AI camp. There's a lot of new things happening with things that you've heard of ChatGPT and large language models. We're using really our own technology to do the analysis on the records. And again, we're looking for those suspective, prospective, retrospective codes in the charts today. And then obviously we're identifying, wait, is this diagnosis, part of the HCC V28 model, or is this outside of that, and tagging that within the data. Now, I think what makes us really unique is that we have humans in the loop as part of that process. And I think most solutions today that are doing clinical analysis of raw encounter notes or data end up with very high false positive rates. And we just don't believe that's the right way to do, you know, sort of this level of HCC coding when you're reviewing clinical data. We really insist on that because it just produces a very high quality outcome. And if you've seen some of our case study results, we're getting a 74% acceptance rate of diagnosis codes. And the reason is we've had a human kind of check over that data alongside the technology. And that's what we call it PredX Copilot for that reason. It's a copilot. It's helping the risk adjuster look through the data and verify, okay, this looks right, this doesn't, I need to modify this. Because really all the high value things are in the unstructured encounter data. If you just pull a problem list and throw that in front of a doctor, that problem list could be from forever ago versus, hey, here's a clinical note from the last 6 months from the endocrinologist that really goes into the state of their diabetes and what's the treatment happening there. That's the type of data that's going to be really informative to the provider, and we think is essential in terms of getting in front of them to help with patient care.
Wonderful. I think we got time for maybe one more, and there's some
Yeah,
great
we're right
questions
at
coming in.
time.
I wish I would ask all of these, but if you have a question, we haven't answered it, don't worry. Someone will reach out via email to answer it. So go ahead and ask it, even if we're just wrapping up at the last second here. This last question is, do you believe that the physician is having to document too much information to capture HCC for risk adjustment?
Well, what I would say is I think coding burden is the problem. I mean, do we really want to believe that providers should be coders? No. They really should be empathetic partners with patients, supporting and taking care of them and trying to identify the diagnosis and not necessarily do the coding. But my emphasis is this is about technology, right? We need to get to a world where we've abstracted that effort that's we've burdened the provider today in terms of documentation and coding, and let the technology do that. And so we've started down that path. When we present a diagnosis, we don't say, you've got to know that this is E45 or 46. We just say, hey, they have, dementia or unspecified protein malnutrition. Do you agree with that based on the clinical data? Yes. And then the system takes care of the rest in terms of the coding. And I think that's the world we should be aiming for with providers. And I think the thing that, I've talked to before on other podcasts is that, it's not that providers don't, dislike technology. They dislike bad technology. And the thing that we've done is a huge disservice to every clinical person in the United States is that we've put bad technology in front of them that has burdened them, that's had led to an environment for every one doctor, we have 100 administrators now because we've employed technology that hasn't, lowered costs and been deflationary in nature. It's increased costs. And that's because the user experience is bad. That's because the providers hate the EHR and they are burdened by it. And technology should not do that. And we all have to wake up to that. We've overcompensated in getting the coding and diagnosis and revenue cycle stuff right, versus how do we create and delight the provider at the point of care and the way they take care of patients, and push the technology to do all the things the doctor shouldn't do and get them back to being empathetic partners with patients. And that's the thing we've got to do. That's the mission we're on at Credo. And hope some of you follow up with us to find out more, and just really appreciate everybody's time today, the great poll questions, and these great follow-up questions at the end have been wonderful. So thank you, Garrett, and everybody for the time today.
Yeah, very, very good. And thank you, Carm. As we wrap up here, I would want to encourage you all to head over to VBC Exhibit Hall .com and check out the booth. Credo has a virtual exhibit booth, which I think, do we have a slide on that, Carm?
Yeah, it could be. Sorry, one
Maybe
more
not.
here. Get
No,
there.
that's all right.
Yep, there we go.
There we go. All right, and there's a little visual of it there, and there's a link in the slides that we're going to share. But it's really cool. There's a lot of great tools there. You can read up on them and what they're doing, and of course contact them through there and see some of the resources and really educate yourself on them. Carm didn't come out and say it, but I'll say it. This is good technology. Credo is good technology, and I think they're really doing some wonderful things. So highly encourage you to reach out to them. And then finally, if you'd like to reach out directly to Carm, to the Credo team. Carm, if you go to that very last slide, I think their contact information is here, it should be. Uh, or
Whoa,
you can, oh, is it
I might
not?
have
All
followed the
right,
link
well,
there.
that's all right. Well, as he's doing that, you feel free to reach out to me directly. I'm happy to facilitate an introduction to the team, and it will be there. You go, and it will be in, of course, the slides that we share with you. So you should receive an email here in a little bit with all this. But thank you guys so much for joining us today. Carm,
Thanks,
thank you
everybody.
for a wonderful presentation. Appreciate you spending the afternoon with us. See you next time. Bye
Thanks
bye.
so much. Bye.